Thanks very much for the introduction, and thanks you everyone for joining here today. I'm just going to share my screen here. I assume you can see that?
It's perfect.
Excellent. Okay, well, thank you for joining today. And as I say, what we're going to do is talk about amphibian sedation and anesthesia. And so today's lecture outline, we'll overgo a brief review of amphibian taxonomy. We'll talk about indications for sedation and anesthesia in amphibians. We're going to review clinically relevant anatomy and physiology. Then we'll talk about some pre-anesthetic procedures to help to ensure a successful anesthesia. We'll talk about the sedation anesthesia in terms of what are the routes of administration and what anesthetic agents do we have in our toolbox to anesthetize amphibians. Talk about how we monitor amphibians under anesthesia, and then finally talk about some post-anesthetic planning because it's also an important procedure. So when we think about amphibians, with over 8,500 species in the world, they certainly represent a significant diversity within the vertebrate taxa. And when we think broadly about the class Amphibia, it's broken down into three orders. So our Anura, which are our frogs and toads, and by far they are the most plentiful amphibians out there, and also the ones that we tend to see most frequently in practices, in zoos, and in research settings. Then we have our Caudata, or also known as our Urodeles. These are our salamanders and newts, and there's about 777 different species of them. And then finally, our Gymnophiona, which are our Sicilian species, and they're not very common in private practice, but you will see on occasion, particularly some of the Typhlonectes species. But you'll also see them in zoos, and they are a common research species as well. So amphibians are increasing in popularity as pets. And when we think about some of the species that may present to clinics, for example, we have things like the red-eyed tree frogs, we've got fire-bellied toads, we've got crested newts, for example, some of the amazing Sicilian species out there, like the Mexican blues, or as I said, the Typhlonectes natans, some of our clod frog species, Argentinian Argentinian horned frogs, which are also known as the Pac-Man frog, species like axolotls, which are very, very popular and actually have been made much more popular with the game Minecraft to the point where we're actually starting to see them starting to show up in shelters as people have got them and then realize the care that's required for them and no longer can take care of them as well. And other species like some of my favorites, tomato frogs. So why do we want to sedate or anesthetize amphibians? Well, certainly some of the things that are common to other species, the same holds true for our amphibian species as well. So certainly the first one is to facilitate diagnostics and treatments. Some amphibians will stay still for some simple diagnostics. Sometimes you can use things like wet paper towel tricks to kind of tamp them down for radiographs, for example. But if you are having to do something that's a little bit more painful, an amphibian's got a broken limb, for example, and you want to get a good radiograph of that, it's really important that we anesthetize them to do that diagnostic and get a really good quality radiograph for that. Also to help facilitate treatments as well. And then obviously, anytime that we have any pain or distress associated with our clinical interventions, we're going to want to anesthetize them. So this could be things for trauma management, which will be one of the most common things that you'll see amphibians for probably in a private practice situation, for reproductive management, particularly in females, for example, that have retained eggs and are getting some infections associated with that, or in cases of surgery where we need to go in and do a surgical procedure on those amphibians. Anesthesia is also important when it comes to euthanizing amphibians because quite often we give them an anesthetic overdose, quite often MS-222, for example, or injectable sodium pentobarbital, both of which are anesthetic drugs, and then have to follow up with ancillary things like pithing, for example, to ensure the death of that amphibian. Okay, so we're going to talk about some of the important clinical and anatomy and physiology when it comes to amphibian species that make them a little bit unique when it comes to anesthesia compared to some of the other vertebrate taxa that you might be familiar working with. The first thing we'll talk about is what's called the preferred optimal temperature zone, or the POTZ. And probably first thing to realize is that amphibians are not small reptiles, and most of you already realize that. But when it comes to their preferred optimal temperature zone, they tend to be much lower than we see in our reptile species. So this is Phelps. He's one of our waxy tree frogs at the zoo. He's actually the frog that I've had to do the most surgeries on. He's had 4 surgeries in his lifetime. He's had a cystotomy to take out a urate stone, and then he's had several eye surgeries as well, because he keeps damaging his left eye and his eyelids and things like that. But as you can see here, I mean, within his enclosure, his temperature is 22.7 degrees Celsius. And whereas a reptile species, most of our reptile species tend to be much higher than that, quite often even in the 30s for some of those species. So when we look at some of the what are called the preferred optimal temperature zones for our amphibian species, if we think about some of these tropical, lowland species, they're going to sit in that 24 to 30 degrees Celsius range. So, when it comes to doing the anesthesia, the pre-anesthetic period, the anesthetic itself, the post-anesthetic recovery period, we want to make sure that we've optimized their environmental temperature and we're keeping them within that 24 to 30 degrees Celsius range. If we look at some of our temperate species, we can see that they tend to sit in that kind of 18 to 24 degrees Celsius range. Our temperate stream species, such as a long-toed salamander, will sit in that kind of 16 to 21 degrees Celsius. So in most cases, we're going to be doing most of these procedures or keeping most of these amphibians around room temperature. So around 19 to 20 degrees Celsius. So depending on where your clinic is located, we may actually have to make some adjustments to the temperatures within the room to help keep these animals within their preferred optimal temperature zone. Because if we have them too high, that actually may influence the metabolism of the drug. Sometimes they will not actually metabolize normally. It also stresses them physiologically when we have them above their preferred optimal temperature zones. So because with most of our species, they tend to kind of be in that 20 to 24 degrees Celsius preferred optimal temperature range. In the majority of cases, supplemental heat is not required either during the sedation or anesthetic procedure. One thing that I have found doing amphibian anesthesias is that quite often, if we can kind of keep them in that preferred optimal temperature zone at the higher end, that sometimes can enhance the recovery speed. So even if we keep them, a little bit lower during their anesthesia, if we can, just slightly warm them up into the high end of the preferred optimal temperature zone, I find that they quite often will return to much normal respiratory pattern, and recovery tends to be a little bit quicker from that. So this is an example of Phelps undergoing a surgery here, and you can see here we've got him about 23.5 degrees Celsius to kind of a higher end of his preferred optimal temperature zone. Okay, so moving on to amphibian respirations, this is really dependent on the life stage and the species that we're dealing with when it comes to how they respirate. So when we think about the two kind of major life stages that we see with our amphibians, so we have our tadpoles or neotenic or larval adult stages, and they really rely on branchial respiration. So all of our tadpole species, for example, or some of our neotenic adults like axolotls will have these gills. And so similar to fish, they'll actually do a lot of gas exchange across those gills. And some of these neotenic adults will actually also have lungs as well, which they can also utilize. And then all of them, either the tadpoles or the neotenic adults will also use cutaneous respirations as well to facilitate gas exchange across their skin. With our adult species, they use a variety of different forms. So the first one was called the bucopharyngeal respiratory pump, or the gular pump. And this is the most effective way that they can, basically pull in oxygen and actually have some oxygen exchange across the moist mucous membranes found within their oral and pharyngeal cavities. But then a lot of that air will then be pushed into the lungs as well. And so pulmonary gas exchange is incredibly important in amphibians that are awake. As well as cutaneous. And one of the big things when it comes to the respirations is that as soon as we anesthetize amphibians, quite often we knock out a lot of the bucopharyngeal and pulmonary respirations that are occurring unless we actually have our adults intubated, for example. And so a lot of the gas exchange is then going to occur across the skin. And it's really important, therefore, to make sure we're keeping that moist. So when we think about the different strategies that our amphibians are employing in terms of respiration, our terrestrial frogs tend to ventilate their lungs with very small tidal volumes and exhale passively. And unlike, our reptile species or our avian or mammal species, which require an aspiration type of event to get that air into the lungs, our frogs and other amphibian species, basically what they'll do is they'll fill their ubicopharyngeal area, the gular area here, with air. So basically they'll draw in air through their nares, through that bucopharyngeal pumping action. And then what they'll do is they'll compress this area here, and that's what ends up forcing the air into the lung. So basically it's a forced ventilation into the lung. And then when it comes to exhalation, with our frog species, they'll actually just have a passive ventilation. So basically, that lung will just start to collapse normally, particularly as they're moving or doing some of that motion. Whereas our aquatic frogs and salamanders actually have larger tidal volumes and actually exhale actively by compressing the musculature along the sides of their wall. And one of the big things in terms of when it comes to amphibian respirations is that the respiratory rates can actually vary tremendously. And it can be anywhere from 4 to 6 breaths per minute, particularly when the amphibian's in a state of high energy or high activity level, and then to 6 breaths per hour, depending on the species. But in general, when we look at some of the studies that have been done in terms of looking at the general range of amphibian respirations, most of the species tend to fall between 20 to 40 breaths per hour. And so, there we're talking about basically anywhere from 0.3 to 0.2 breaths per minute when it comes to that. So when we have them under anesthesia, we don't actually have to breathe a lot for amphibians to make sure that they're actually successfully and effectively ventilating their lungs. So as I said before, though, one of the important things is as soon as we anesthetize amphibians, most of the time we tend up to knocking out their bucopharyngeal or gular movements of getting air into the lungs. And therefore, they basically go into relying heavily on cutaneous respirations. So it's really important to make sure that when we have amphibians under anesthesia, we keep them wet the entire time during that anesthesia. And we can do that a variety of different ways, and I'll show you that as we go further into this presentation. But that's going to really facilitate that gas exchange across those moist mucous membranes, or moist skin, I should say. So arguably, the skin is the most important organ when it comes to amphibians. It's responsible for fluid and electrolyte homeostasis of amphibians. Most amphibians will have what's called a ventral drinking patch, which is on the ventral aspect of their legs here and into their pelvic area here, which allows them to both diffuse water as well as electrolytes across their skin. And then, as I say, it's also important for that gas exchange across their skin. And depending on the species, some species rely heavily on that gas exchange to eliminate carbon dioxide, whereas the lungs will be the primary area for oxygen exchange. And then in other species, they'll actually rely heavily on simply gas exchange across their skin for both oxygen acceptance as well as carbon dioxide diffusion. And then the skin's also important for thermoregulation and reproductive functions as well. But as I say, one of the most effective things we can do in terms of amphibians, in terms of hydrating them, for example, is to make sure that we can actually get them into a good quality soak there. And wouldn't it be wonderful if we could do that with some of our other species? Okay, so the first thing we're going to do then, in terms of our pre-anesthetic examination, is we're going to start off with a distant examination. And what we want to do that, we're going to assess their body condition. We can kind of look at, over their pelvic areas, look over their limbs to see, how much muscling they have over there. Remember that amphibians don't carry subcutaneous fat. All their fat's going to be within their coelomic cavity within their fat bodies. And so, we can actually look at the, how large those coelom is in the amphibians, but quite often amphibians, once they're stressed, also start to puff up their lungs as well, which can make it sometimes difficult to assess that. Big thing though is, we can gently look at their activity level within their enclosures that they're brought into the hospital or they're in the before their anesthetic procedure, and look at their response to stimuli. We want to look at their posture, right? So a healthy amphibian, should be able to push up with their front limbs quite easily. They're not going to be flattened out there as well. We're going to look at their movement, look at their skin color and their condition. We're going to look for any evidence of trauma. And this is a great place then next that we can actually assess their respiratory rate and effort as well. So it's always important to make sure we get a weight on our amphibians. It allows us to accurately dose the drugs that we're going to be using, particularly if we're using something like an injectable anesthetic combination. It also allows us to look for changes in hydration status, but particularly if we want to look at what their weight was before and after a soak, for example. But it also allows us then to look at what are the effects of the anesthesia and to see whether we have animals that lose weight, for example, after anesthetic procedures, particularly in the following week. We're going to do an efficient physical examination next. We want to have minimal restraint. We're doing the examination. Remember that amphibians don't have ribs like our reptile species do, and so it's very easy to crush the contents of their coelomic cavity. So what we want to do is to make sure that we're, using minimal restraint, but obviously a lot of amphibians will try to jump away. They're very good at trying to escape, and so we also want to make sure that we're using enough restraint to keep them from escaping. And then we can monitor that gular movement for the respiratory rate monitoring. And so when we talk about the gular movement here, you can see here in this little horn frog here, that bucopharyngeal pumping that's going on. So that's what that's doing is drawing air in through the nares into that oral cavity. And then as they compress, and they're actually compressing their lungs, you'll often see a little bit of coelomic movement as well along the sides, to kind of help facilitate as well. But most of the effective respirations are going to be through that gular movement, less effective through the coelomic pumping that's occurring there. Okay, and then we're going to want to get a resting heart rate before we begin the anesthesia. And there's various ways that we can do that. Once again, doing this in kind of a non-stressful way for the amphibian. So I like to do this quite often when I'm doing a pre-anesthetic hydration soak. So I always will do a pre-anesthetic hydration soak. And, we can either do that, by just throwing on an ultrasound. And as you can see here, we can just ultrasound through the bottom of this plastic container. I find that, sometimes these really cheap salad containers are some of the best things when it comes to being able to ultrasound amphibians. The plastic is so thin it doesn't interfere, with the good signal strength with either the ultrasound or the Doppler ultrasound. And the other nice thing is that they're strong enough to contain the amphibian and they're not compressing them. So some people like to use plastic bags for the amphibians, and I certainly have used plastic bags as well. But I find sometimes they kind of collapse around the amphibian and it's harder to actually get them into a comfortable position. Whereas I find these little plastic containers, allow them to stay within a very comfortable position during the procedure. I can certainly cover them over with a towel or something to darken them as well. And they're a lot less stressed within these containers during that pre-anesthetic soak. And so here, I say we're just using a linear probe to measure the heart rate on this leopard frog, or you can also put your Doppler ultrasound as well, just once again underneath the xiphoid area of that frog, and be able to get that heart rate before you do your anesthesia. And then the other thing is that in some salamander species, I've actually found that they actually have a pretty good temporal pulse. And so our tiger salamanders, our long-toed salamanders, for example, you can actually look along the temporal area and actually pick up a pulse on them as well. And that's a great way to get that heart rate before your anesthetic procedure. So pre-anesthetic blood work, certainly it is something that some people will do, particularly if they think they have a compromised amphibian. The big thing though is you have to really ask yourself, similar to the way it's been asked in other aspects of veterinary medicine, is it going to change how you approach your anesthetic procedure? And if your answer is yes, then you definitely go ahead with that pre-anesthetic blood work. But if not, then this is something that can actually be collected while the animal is under anesthesia, and then you can modify your treatment plans afterwards based on that anesthesia. Just to review in terms of how do we collect blood from amphibians, we can certainly use the ventral midline vein, and so it runs right along midline. This is the xiphoid area where the heart is sitting, and it runs right down into the pelvic area. I tend to go usually in that bottom third I find that tends to be the most successful area to collect blood. You can also use transillumination to highlight that vessel as well. And quite often I'll actually bend my needle a little bit to make it a little easier when it comes to collecting from that blood. It can be a little challenging. As you can see, the amphibians will often puff up as well. So sometimes when they puff up, they can actually end up collapsing that vein. But as they just, very, very shallow, right on midline. The other place that I really prefer to collect blood is from the femoral vein. And what I do is I'll palpate kind of for the stifle or knee area there, and I'm just behind the knee when it comes to collecting blood. And you can collect a significant amount of blood from this area in our frog species as well. In our salamander species, they obviously have a tail, so we can actually collect from the ventrococcygeal vein, and we can approach that vein either from a ventral aspect or from a lateral aspect. And it's once again, it's the preference of the clinician. I've done it both ways. I tend to go lateral, similar to my reptile species. I tend to like to collect from the lateral aspect. I find it doesn't collapse the vein as easily as I'm doing my blood work. Okay, so the next thing in terms of our pre-anesthetic preparation is our hydration soak. And so just recalling, with amphibians, the plasma osmolality of amphibians tends to run between 200 to 250 milliosmoles per liter, depending on the species. And to kind of have our physiology flashback, how do we calculate plasma osmolality? Well, it's 2 times the sodium concentration plus urea plus glucose. Well, our glucose levels in amphibian species tend to be very, very low and often less than 1.5, 1.6 millimoles per liter. So I tend not to kind of use that. Amphibian species, most of the species tend to be urea excreting as their primary nitrogenous waste product. Once again, tend to have very low urea levels. So kind of the quick and dirty way is I kind of look at the species and look at what is the sodium concentration for that species or the next closely related species, and just 2 times the sodium is our plasma osmolality. So what we're going to do there is we want to make sure that in those cases that we keep that plasma osmolality of the fluids that we're using and thinking about those fluids, and we want to make sure that whatever fluid we're using is lower than the plasma osmolality, because that will facilitate a normal osmotic gradient across the skin. And so what I like to use, we can use things like Plasmolite or Normosol. Those tend to be my favorite to use. They're balanced electrolyte solutions. You can make amphibian ringers. A lot of people would like their amphibian ringers solutions. I found in the past, 2 decades of practice that I've had no difference in terms of the response in terms of using something that's already commercially available, as opposed to having to keep the ingredients to make amphibian ringer solution. And so I tend to use Plasmolite or Normosol. Some people will use LRS as well. One of the reasons I don't like using LRS is that amphibians don't have the buffering systems in place that reptiles have. And so if there's any sort of lactic acidosis that's built up within those amphibians, there is the possibility that you may actually worsen that with LRS. It's something that needs to be studied a little bit more. But for those very reasons, I use Plasmolite because it already comes with a 7.4 pH. And so what I do is I mix that Plasmolite 50-50 with some sort of dechlorinated water, clean dechlorinated water. So that can either be aged water, so that means I let it sit for at least 24 hours with some aeration to get rid of those chlorines within the water. If you're in an area that actually has chloramines, you're going to actually end up having to use some charcoal filtration as well, or carbon filtration, to basically draw out the chloramines that would be in the water as well, because the aging process doesn't get rid of the chloramines. And the other thing you can also use is things like bottled water or sterile water, distilled water have often been used as well, for this. So I say mix it 50-50. That ensures that we get our plasma osmolality below 200, because the osmolality of Plasmolite, for example, is 294. And so when we divide it, we're sitting at around about 150 milliosmoles per liter. And then I like to sit them in that soak for about 30 minutes at least, maybe a little bit longer if you can. As I say, you can just keep them in a nice quiet dark spot. Let them sit in their little container. I usually do make sure that I have that just kind of at the level of the shoulders, so that they're not going to drown within that solution. Particularly if it's an amphibian that tends to be compromised, you're going to watch them a little bit more. as well. And then as we're doing that, we can start to think about our other peri-anesthetic considerations in terms of analgesics that might be needed, or any sort of antibiosis, whether it's antibiotics or antifungals, for example, that might be needed during or after the procedure. Okay, so moving on to our routes of administration, definitely one of the things we're going to consider in terms of routes of administration is we're going to consider the life stage. So are we dealing with a larval amphibian, so a tadpole, for example, or are we dealing with an adult? What is the procedure that we're doing? Do we need sedation? Do we need proper deep anesthesia, surgical anesthesia? And then, excuse me, depending on the area of the world, we're going to look at drug availability as well. So our first route of administration that we can use is what's called immersion, or also known as a bath. And anytime that we're going to be using that, we want to make sure that we are using high quality water. So it's going to be dechlorinated, as I talked about before, and we're going to keep that within the preferred optimal temperature zone. And we're able to use this route successfully in amphibians because of their highly vascular and permeable skin. And something that obviously we can't do in other vertebrate species. Whenever we're going to be using any sort of immersion bath, we want to make sure that we're aerating the water. It's really important to make sure that we have really well oxygenated water for these amphibians, because a lot of the drugs that we're using, particularly things like MS-222, are going to decrease the oxygenation in the water and decrease the oxygen saturation within the blood. Whatever container we're using, we want to make sure it's watertight and it's secure, so the amphibian can't escape from it. We definitely want to keep them, quiet, so reduce our light and noise to reduce that stimulation. As I said before, we want to keep the solution below the level of the shoulder, and that allows to make sure that that amphibian is not going to drown within it. Definitely want to monitor closely during induction, because as that amphibian starts to become more and more sedate, that head can drop below the water, and so once again, we may end up having to remove some of that or get the amphibian out quicker. And the big thing is, whenever we're using these immersions, apnea is not uncommon. So once we have that animal anesthetized, we're going to have to remove them, from it afterwards, and then we, can drip additional anesthetic onto the amphibian should additional anesthesia be needed. The other route we can use is topical or direct. And the nice thing about that is that we can often use undiluted. So therefore, we can use smaller doses and volumes of this drug. But quite often, because they're applied directly to the skin, we have a greater chance of toxicity. And that toxicity can be dose dependent, but also can be species dependent. So sometimes we'll use a drug, for example, EMLA cream, in one species, which will cause no issue, but in another species can actually end up killing that species. So something we always want to be aware of, and make sure that we're using a very metered dose when it comes to these topical administrations. Historically, parental routes of administration haven't been used that much in amphibians, but I think it's something certainly that's becoming more and more commonplace for a variety of different reasons. And intramuscular is the most common route that we tend to do with that. And big thing is, when we're doing intramuscular routes, is we want to make sure we're avoiding the hind limbs due to that renal portal system. So as we recall, in our fish, amphibians, reptile, and avian species, we have this renal portal system, which the blood flowing from the hind quarters of the body will actually end up going through the kidneys before it gets back into general circulation. And so any drug that we give in the caudal half of the body can have that first pass effect going through the kidneys. And if it's a drug that either has some renal elimination or has some renal toxicity, that can be a problem. So in general, we try to avoid the hind limbs because of it. We don't really know in amphibian species how much it will influence drug kinetics, but to be on the safe side, we tend to inject into the forelimbs instead. Some people will also inject into the dorsal lymph sacs, over top of the pelvic area, for example. Intravenous routes, if you have access to an IV route, can also be used, and then intracellular routes also have been explored. Certainly, one of the things in amphibian species is because their peritoneal cavities are very well vascularized, it is well absorbed, but what we find with our intrathalamic route compared to other routes is it tends to be quite often delayed. And then inhalation is another route that we can use as well. So we can do either chamber inductions, and there's a variety of different ways that we can create chambers for inhalation anesthesia. And then quite often what we'll do is we'll intubate after induction for longer procedures. Big thing with amphibians is they have a very, very short trachea, so you have to be aware of that, that we don't end up inadvertently intubating into one lung. And a variety of different things can be used for our endotracheal tubes, so things like IV catheters or red rubber feeding tubes tend to be my favorites in terms of intubating. Nasogastric tubes can also be used as endotracheal tubes. And then when we have, amphibians under inhalant anesthesia, particularly for longer procedures, we're going to want to use intermittent positive pressure ventilation, because as soon as we have them anesthetized, most amphibians will actually stop breathing on their own. But as I say, because of their low normal respiratory rates, anywhere from 20 to 40 kind of breaths per hour, I tend to kind of go in the middle of that. And so one breath every 2 minutes is quite often enough to ensure that amphibians remain well oxygen saturated and we have good carbon dioxide exchange as well during that anesthesia. Big thing though is as we look at the ventilation pressures, compared to some of the other species that we deal with, as you can see, there's tremendous variation depending on whether it's a much more terrestrial amphibian or whether it's more of a water-based or semi-aquatic amphibian. So in some of our toad species, our Bufonidae species, as you can see, less than 5 millimeters of mercury is our ventilation pressure. In our Ranidae species, so you think about things like leopard frogs and bullfrogs and things like that, less than 3.6. And then some of our, very aquatic frogs, the Bividae, less than 2.6 millimeters of mercury. It's been very poorly studied in salamander species. Much more, research has been done in our frog species, but in one species, the amphibia, it was less than 10.3 millimeters of mercury as well. So very, very low ventilation pressure. So we have to be really, really careful about ventilating these amphibians, because we can end up damaging their lungs very easily if we overpressurize them. Okay, so moving on to our anesthetic options. So our anesthetic options, include MS-222 or methane sulfonate, benzocaine, clove oils, the inhalant halogens, propofol, avaxolone, etomidate, we can more commonly use, and then some injectable combinations as well. So we'll go over all of these as well. So by far, the most common thing that is used to anesthetize amphibians still is methane sulfonate, or MS-222. One of the reasons it's really liked is that it's readily available because of the fish industry. It's water soluble. One of the big things, though, it is strongly acidic, and so we want to make sure that when we're using it, we always buffer it at least 1-to-1, and quite often I'll use 2-to-1 sodium bicarbonate to the MS-22. And the reason why we want to make sure that we're buffering it is, one, it can be very irritating to the amphibian with such a low pH, but also what happens is that it can start to ionize once it's in solution, and therefore it's actually less effective if we actually don't have it buffered. So always make sure we buffer it, as I say, minimum 1-to-1, and if better, 2-to-1 with sodium bicarbonate. Big thing when we're using MS-222 is it can really drop the oxygen saturation with our amphibian species. And so we really want to make sure we have that water well oxygenated to make sure that we've kind of almost super oxygenated our amphibians before they become anesthetized. And so we want to make sure that we're keeping that above that, 5 parts per million in terms of the oxygen saturation of the water. And we can do that a variety of different ways, but the big thing is quite often we'll just use an air stone, either with a commercial fish pump, or we can use actually straight off the oxygen line as well, just to make sure that we're oxygenating that water. And then we obviously make sure it's a watertight container, and you'll have partial or full immersion depending on the species, whether it's a semi-aquatic or an aquatic species or a terrestrial species when it comes to anesthetizing them. Other big thing to do with use of MS-222 is make sure that you're always wearing gloves. There is a potential carcinogenic activity associated with MS-222, particularly with multiple uses over time. And it's one of the reasons why it's starting to fall out of favor is because of the potential human health hazards associated with it, even though it is probably one of the most effective and safe anesthesias we can use within our amphibian species. So it has a dose-dependent action, but in general, the induction times tend to be 10 to 30 minutes, depending on the species. Once we actually have them induced, big thing is we want to make sure we remove them from the solution, because if we leave them within the solution, then we can start to compromise that amphibian, and recovery will be much longer. If we find that we have a prolonged anesthesia, we can use top-ups, which is basically dripping some solution at 20 to 50% of the induction dose on there. And so, you can do that occasionally, and you're going to monitor that anesthesia based on what the heart rate is doing, or what the Gula rate is doing, for example. Some people like to do water changes for prolonged procedures, particularly if we're going to actually have the amphibian in the water for that entire procedure, just simply because some of the nitrogenous waste, for example, can build up within that water, and rinsing with clean dechlorinated water actually helps aid in recovery afterwards, get any of that residual MS-222 solution that may be on the skin of that amphibian here. And so this is an example of a long-tailed salamander that's undergoing anesthesia. You can see here, just the water level is basically kind of keeping it once again at that shoulder level, but the little nares are still above the solution here. And then I just have an air stone that's been bubbling through here as well to make sure it's well oxygenated. And so if we look at some of the studies that have been done and what some of the work that we've done in our zoo over the years, for example, you can see here the range in terms of MS-222 is really dependent on the species. In Rheococcus siciliens, for example, 1 gram per liter gave us an anesthetic duration of 70 to 160 minutes. If we look at some of our salamander species, you can see that tiger salamanders tend to be a little bit more sensitive, to MS-222 compared to axolotls. In axolotls, 2 to 4 grams will give us surgical anesthesia only 15 to 30 minutes, whereas in our tiger salamanders, we'll get about 35 to 43 minutes, depending on what we're doing and the concentration we're using. I tend to use the higher dose in tiger salamanders. I tend to go with that 1 gram per liter because I like that bit longer anesthetic duration that we see with that. And then as you can see here, a whole variety of different ranges for some of the frog species and our little Pac-Man frogs, our Argentinian horn frogs. We get about 10 to 15 minutes, with 0.25 to 0.5 grams per liter. They usually become induced in about 15 to 20 minutes with that dose. So very good for a very, short procedure, for example. With marine toads, a little bit higher, 2 grams per liter gives us that 80 to 100 minutes. But as you can see here, most of the time we tend to be anywhere from that 30 to 80 minutes, depending on the species that we're using. And this table has been provided for you afterwards. So moving on to benzocaine. So MS-222 is a derivative of benzocaine. So benzocaine is a topical anesthetic that is used for tooth pain, for example, in people. But what we found is that in amphibian species, it can be used either topically or as an immersion application. The nice thing is when you make up these stock solutions of benzocaine, they tend to be stable for about 2 weeks, which makes it really nice if you are in a practice that tends to see a lot of amphibians, or you're doing a research procedure, for example, that you're going to be doing a lot of amphibian anesthesias over a short period. The anesthetic inductions are quite often less predictable, though, than MS-222, and they tend to be quicker. And so benzocaine is actually a solution. If you put too much on the amphibian, can actually effectively euthanize your amphibian. So we got to be really careful when we're using that and make sure that we're carefully calculating out the dose. One of the interesting things compared to most of the other anesthetic drugs that we use in our amphibian species is the heart rates actually can increase rather than decrease when we use benzocaine, and no one really knows the reason for that, but it is something to be aware of, because if you're trying to monitor surgical anesthesia and you think the animal is actually getting light because the heart rate actually has gone up compared to your base, it may actually just be the benzocaine as opposed to the animal actually getting light. And a lot of people like it because it is more economical than MS-222. It's about less than half the price to do an anesthetic. And so if we look at in select species, it's been used in red-spotted newts. 2 grams per liter gave an anesthetic duration of about 20 minutes. In tiger salamanders, I've used it at 0.2 grams per liter. It does give you a rapid induction, but I find that the recoveries are actually longer than MS-222, so I don't tend to use it as much as well. In marine toads, they've been anesthetized successfully within about 5 minutes with benzocaine, so really quick onset of action using that 1 gram per liter. And they use their corneal reflex and are in an anesthetic plane that allowed for femoral artery catheterization within those studies as well. In leopard frogs, that 2.3 milligrams per gram topical application gave us about 67% induction, but only less than 50% of animals actually had surgical anesthesia as well. And then an African clawed frog solution of 1 gram per liter gives us an anesthetic duration of about 40 minutes. So another thing that's been used more and more in the fish industry and started to come over into to amphibian anesthesia, it's clove oil, and lots of different ingredients in there, but the most active is the isoeugenol, and can be used as an immersion. One of the things with clove oil is that the induction times tend to be highly variable, and the recovery times are actually longer than MS-222. And then one of the other challenges with clove oil in some species is that there's actually been some pathology associated with it. So renal apoptosis and hepatic necrosis has been associated with it. And one of the reasons I really don't like using it is that gastric prolapse that can occur. In one study, by Gwinnett Dallaire in 2006, in a leopard frog study, they showed that 50% of leopard frogs actually prolapsed their stomachs as a result of that. I mean, the stomachs, they are easily replaced, but still it can be a little bit unnerving, particularly if it happens, in the presence of an owner, for example. And so for those reasons, I tend not to use clove oil. As say the concentrations that are being used, anywhere from 250 to 450 milligrams per liter. But as you can see here, it doesn't really produce a lot of great surgical anesthesia. In this case here with the tiger salamanders at really high concentrations, less than 2/3 or a third of the animals were not actually surgically anesthetized. And you can see in here leopard frogs as well, less than 50% are actually achieving surgical anesthesia as well. So for those reasons, I don't recommend clove oil. Some people still like to use it, but I think there's better alternatives out there. So moving on to our inhalant anesthesics, so we can use things like isoflurane or sevoflurane, and we can use these in a variety of different ways. We can use them as immersions, so basically creating a bath with that isoflurane or sevoflurane topically or inhaled. What I've found is that open drop with a saturated gauze has the most rapid onset and less stressful than meter amounts in airtight containers. Even when you darken up those containers, sometimes the amphibians really go through a kind of a prolonged excitement phase, whereas with this open drop, I find that they tend to have an excitement phase, but usually not as long. And one of the things I like about using these inhalant halogens is they're really good for kind of these really short procedures because they have a short duration of anesthesia in most cases. So if you're going to use them by immersion, usually what you do is you'll add 2 to 3 mLs of the inhalant to 1 liter of water, and then you can actually have the amphibian within there as well. Got to be really careful though in terms of bubbling the water when you do this, because that actually presents a health risk to humans when you do so as well. Topically, people can use this in a gel, and so what you do is you basically take 1 part isoflurane to 1 part water to 0.5 parts of a soluble gel, mix it all together, and you can apply that topically to your amphibian. You can often put a piece of gauze, for example, over top to keep it in place as well. And you're going to use about 0.025 or basically 0.03 to 0.04 mLs per gram of body weight of the amphibian to do that. And it gives you about 45 to 80 minutes of really good anesthetic time by doing so. And so this is really kind of good for diagnostics. One of the things that we find though with the halogens is that quite often we don't get a great level of surgical anesthesia associated with it. And so I always recommend that adjunctive analgesia is is provided for surgical or painful procedures, and that might be using a local anesthetic, for example, or using either dexmedetomidine or an opioid for pain relief. And then this is just an example of one of our tiger salamanders undergoing that. So what I like to do is I created just basically a little container. You can see I've drilled a bunch of little holes in there, and I put the saturated gauze within that container, so that way the amphibian's not going to be climbing over top of it and being irritated by it. And then I have this kind of wet, moist paper towel around there to help kind of keep it protected as it goes through that excitement phase as well. So alfoxylone is something that's gaining more and more popularity in terms of looking at what is its potential for using it for sedation or anesthesia in amphibians. One of the interesting things, though, is that even though it is quite successful at sedating amphibians, it doesn't seem to provide anesthesia in the studied species on its own. And so adjunctive analgesia is always going to be needed if you're using alfoxylone for a surgical procedure, for example. It's been given IM and sub-Q and also immersion studies, and sedation, depending on the species, can occur within 5 to 20 minutes, with the onset of action being very dose dependent. So the higher the dose, quite often the quicker the onset of action associated with that. So there's been a number of different studies that have been carried out with alfoxylone. In Spanish ribbed newts, you can see here 15 to 30 mg per kg. They lost their writing reflex, but they were still responsive to noxious stimuli. Same thing with our bullfrog, is still responsive to that noxious stimuli as well. And as you can see here, an immersion study looking at 2 grams per liter gave us about 10 to 30 minutes of sedation, depending on the species. IM doses, 40 to 60 minutes. What I found clinically is that kind of that 20 to 30 mg per kg IM in a clinical setting has been most effective for providing really good sedation to be able to do some diagnostic procedures across a wide variety of amphibian species. So propofol was something that has been looked at historically, and as you can see here, it can be given intravenously or intracelomically. It had not studied well, but in one study that was done by La Fortune, they looked at waste tree frogs. A 9.5 milligram per kilogram intracelemic dose provided sedation. 30 milligrams per kilogram, so almost 3 times that dose, or a little over 3 times that dose, was needed for anesthesia. And if it got too high, 53 milligrams per kilogram resulted in death. But the challenge being with this study was only 3 frogs that were done, so a very, very small group of frogs. In tiger salamanders, one study that looked at there, 25 milligrams per kilogram resulted in about 40% of animals becoming anesthetized, 35 milligrams per kilogram, 83% anesthetized. Also, immersion studies have been looked at, but one of the things is that in the immersion studies, most of them have very, very poor response to that, and in higher doses, it actually ended up killing individuals as well. So for those reasons, I usually don't recommend propofol anesthesia. As I say, we've got better anesthetic drug selection available, alfoxylone, for example, if we want to get some good sedation. So what about some of the other things that are coming online? Well, certainly etomidate certainly holds promise. It's something that's not, very widely available, but looking at studies that have been done in xenopus, it does cause, nice induction within 15 minutes and gives us about 30 minutes of duration. The sister compound, metomidate hydrochloride, in leopard frogs actually failed to produce any sedation in them, but caused really, really long anesthesia in them causes sedation only, but then really, really long recoveries, up to 5 to 10 hours sometimes as well. So that's obviously not something that's very desirable in terms of getting these animals recovered from anesthesia. And then dissociative anesthetics, one of the things is the dissociative anesthetics, things like ketamine or tilazol, have also been studied in amphibians. Often really high doses of ketamine, for example, are used, anywhere from 70 to 100 milligrams per kilogram in some studies. It's been associated with rigidity, poor analgesia, and then really, really long recovery times, anywhere from 12 to 32 hours. And so obviously on its own, it's not going to be very practical to use, particularly tilazol, for example, with a 32-hour recovery time. And so for those reasons, I don't recommend using them on their own. And I usually don't even use them in combination. So what holds more promise is if you want to look at some of the injectable combinations. And one of the nice things about injectable combinations is that we're getting better at using combinations that have at least some partial reversibility to them. And so one of the ones that's been studied, a bit more in the last few years are things combining an alpha-2 agonist plus alfaxalone. So the most common one that's used is dexmedetomidine with alfaxalone. And this has been in the literature, and I've used this combination quite a bit in our frog species at the zoo as well. And as you can see with our dexmedetomidine, we're using pretty high doses, so anywhere from 0.07 to 0.1 milligrams per kilogram. And that's pretty good in terms of providing an effective dose. We know that we can go even higher within some amphibian species. I can see in a study with blue poison arrow frogs, they used 5 milligrams per kilogram of dexmedetomidine. And what we know about dexmedetomidine is that the analgesic properties are great in amphibian species. It doesn't really cause a lot of sedation on its own, but in combination, it seems to be really, really nice as well. And so this combination is the one that I tend to use a lot, is that dexmedetomidine plus alfaxalone. And I find that it results in really rapid loss of the righting reflex. So often within 5 minutes, these animals have lost their righting reflex as well. And then we can actually partially reverse them afterwards with atipamezole. And that will actually help to enhance the recovery in those species. And so this is just an example of Phelpsy under anesthesia. And so I had him sedated here. He had actually torn his eyelid and on a branch, and so we were just suturing his eyelid back together again. But as you can see here, once I have them under anesthesia, what I'll often do is I'll just basically cloak them in these really wet paper towels, and then I just use a flow-by oxygen system because it's going to be a short procedure as opposed to intubating him for this procedure, and basically keep dripping on top of him to keep him really moist, because when that oxygen is flowing over top of him, it's going to rapidly dry him out as well. So you want to make sure you keep him really moist during the procedure. But I find that they do really, really well by just using this flow by oxygen. In most cases, I find that, particularly for shorter procedures, just flow by oxygen is more than enough to keep them well oxygenated, and they recover quite nicely after anesthesia. Once again, if it's going to be a longer procedure, when I did a hysterectomy, for example, I made sure I intubated them and gave them that one breath every 2 minutes. Okay, so moving on to anesthetic monitoring. When it comes to monitoring and responses, what we're going to look for, one of the first things that's going to become absent is our escape response. As I say, amphibians, they have that natural want to escape from predator response there. And then we're going to lose our righting reflex. So if we turn the animal over, they're not going to be able to right themselves afterwards. You can see here, we've turned it over and basically just in a nice relaxed position there. And then we're going to start to lose our superficial and deep pain. So our superficial goes first, our deep pain goes second. When they start to recover, it's the reverse. So deep pain comes back first, and then superficial pain comes back second. We can look at our palpebral or our eyelid blink response, and then the corneal reflex. So when amphibians are really deeply anesthetized, they'll lose their corneal reflex as well. Very different compared to mammals. We have a mammal that loses corneal reflex, it's dead, but not the case with our amphibian species. And then I like to use a rank scale. So basically, is it present, is it delayed, or is it absent? And that kind of helps you gauge in terms of where our anesthetic depth is in those species. And so when we look at heart rate, so even though we can, often visualize the apical heart rate just underneath the xiphoid process, most of the time we're going to use something like a Doppler ultrasound. And so when we're monitoring heart rate, if we have a decline of more than 20% from where our baseline was that we established at the beginning of anesthesia, that amphibian is too deep. And so we want to make sure that if we're using any sort of anesthetic bath, for example, that we have it out of that anesthetic bath, rinse it off. We're not going to continue to drip anesthetic drug onto it, for example. And depending on where you are in your procedure, if that heart rate starts to decline more and you've used an injectable, this might be where you start to do a partial reversal as well. And as I said before, we're going to monitor that with a Doppler ultrasound or an ultrasound as well. We can use a pulse oximeter in amphibians. Just be careful we don't crush their little digits by using that. But some of the nice pulse oximeters these days are very, very gentle. Big thing is that the readings we get with a pulse oximeter aren't very accurate quite often. They're designed based on mammalian physiology, and what we're looking for is trends quite often with our pulse ox in terms of oxygen saturation, for example, as opposed to actual absolute numbers when it comes to that. EKGs can be used. Once again, you got to be really careful with the clips. Some of them have softer clips, or what you can do is use a very small gauge needle, put that through the skin, and then clip your EKG onto that. And that's a great way of being able to monitor their EKG, their electrical activity in the heart afterwards. And this is just a little white tree frog here, starting to recover, and you can see, how quickly that heart rate has come back compared to what it would have been previously. And then finally, in terms of the respiratory system, as I say, most of the time under anesthesia, they're going to lose their gular pumping and the coelomic breaths. And quite often, as they start to recover, the first thing we see is those coelomic breaths start to come back, and then the gular pumping will resume. So this is an example of that occurring. Just watch the side here. So it can be very, very subtle. And as I say, quite often you'll just see that kind of little bit of movement occurring within the coelomic cavity as well. And then the next thing is those gular pumps are going to start to come back. So your animal's starting to become lighter and lighter as we start to go through that transition. And then finally, in terms of our post-anesthetic planning, big thing is we want to make sure that you don't put that amphibian into a fully aquatic environment until it's fully recovered, because they will drown. And so once again, we're going to make sure that we just keep them nice and moist as they're recovering. So quite often, once again, I'll just use these unbleached paper towels, even for aquatic species, and then I can just drip some solution over their backs if need be, or sometimes just place it gently over top of them to kind of create like a little burrow of wet moistened paper towel there as well. And then you want to keep them in a quiet area with within their appropriate preferred optimal temperature zone and humidity. Sometimes what we'll do is I'll just put them on my desk right beside me, because my office tends to sit in that 20 to 21 degrees Celsius range, and just allows me to kind of monitor them closely if I have to do something else, because sometimes they can take up to an hour or an hour and a half sometimes to recover from anesthesia. And so it might gives you a chance to kind of do some other stuff as you're watching them recover from anesthesia, and respond to them quite immediately if you need to do something. And then last thing is to make sure that we're considering any post-anesthetic analgesic requirements or other treatments as indicated as well, because you're going to want to make sure that you've warned your owner about that, and that you're able to go over that, any additional treatments that might be needed, particularly if it's been a painful procedure and you want to continue analgesia for several days after the procedure. So thank you very much for joining today, and I'd be happy to answer any questions that you might have now.
Thank you so much, Dr. Whiteside. I am going to take over the share screen. Get your picture off of there. Okay, so before we begin our question and answer session, there are a few housekeeping items that we need to cover. This webinar is approved for 1 credit hour, and all attendees of the majority of Dr. Whiteside's presentation will receive a continuing education certificate by email later today. Also, on his LeFeverVet webinar page, Dr. Whiteside has generously shared a table for download that summarizes the sedatives and anesthetics that he mentioned in his presentation. Actually, I think I should do a quick question while there's probably more people in the room. The table includes etomidate, and from what you said, maybe it shouldn't. So maybe I should take that off of there, or just add to the comments the prolonged recovery of potentially up to 5 hours. What would you say to?
Oh, sorry, that was with a sister compound, metomidate. So
okay.
Yeah, so we're fine to leave that there. Yeah.
Okay. Let's see what else. If you would like to test your knowledge, links to the quiz have been shared through the chat box and are also displayed on the screen. A direct link to the brief quiz is also posted on Dr. Whiteside's webinar page on Lefebvre Vet. If you don't see the link when you go to his webinar page, immediately just try refreshing the page. Later today, you will also receive a second email campaign from Lefebvre Vet, which will include links to the evaluation form and the brief quiz. And if you would like to take the online quiz, please know that Lefebvre Vet uses an automated grading system. So you will need to complete the free registration process and log in to access that quiz. 2 quick notes. First, after registration, it will be necessary to verify your email address. We pretty much have to do this for most websites nowadays, so please look for that verification email sent from Lefebvre Vet. Second, if it has been some time since you've logged into Lefebvre Vet and the system does not recognize your username, then the simplest way to proceed is to re-register, but you're also more than welcome to contact us with any questions or concerns that arise. The recording of today's seminar has already been approved by the American Association of Veterinary State Boards, and if all goes as planned, the recording will be posted this Thursday, December 15th. I'm telling you this because when the recording is posted, the certificate will be updated to read non-interactive, but again, all attendees of this live event will the majority of this live event will receive a continuing education certificate by email later today. So we're just about ready to begin the Q&A session. Although we hope you will be able to stay for the questions and answers. This session is not considered part of the presentation, and therefore your presence is not necessary to receive a CE certificate. So we've had some questions or comments by some people, so just wanted to make sure that's clear. Also, we'll make every effort to address your questions entered through the Q&A feature, but it is possible we'll run out of time during our live session. There's a lot of you out there. So if that happens, I will follow up with you by email after consulting with Dr. Whiteside. All questions answered by email will also be posted to his webinar page on Lefebvre Vet, so stay tuned for that, but that will be at a later date. I would also ask that you please be considerate of Dr. Whiteside's time. This is an interactive process, and we are so glad that you all are here. If you have a burning question about amphibian sedation and anesthesia, it is important to me and to our speaker that your concern is addressed. However, you have multiple questions for Dr. Whiteside. I encourage you to try to pick 1 or 2, maybe 3, but don't go crazy with the questions. He has a life. Okay, so having said that, let's see, we have lots of really great questions. A lot of people upvoted Primrose's question, which actually is about handling and restraint. She wrote, when handling amphibians, we're taught to wet our hands first. Do you prefer using certain kinds of water, tap water versus distilled water?
Yeah, great question. So the first thing is, I always recommend that you wear nitrile gloves when handling amphibians to protect the amphibian from anything that might be on your hands. Plus, our hands tend to be very rough, almost like sandpaper to amphibian skin, so it can actually damage the skin. So I always recommend that you wear gloves first of all, and then yes, usually what you want to do is you want to wet your hands, and so what you can use is either the water that the amphibian's coming from, or you can use aged water as well as, say, that water that's been dechlorinated, or you can use dechlorinated water, with a thiosulfate, for example. Yeah.
Thank you. Janet had a 3-part question. I think the middle part's been addressed because you certainly get into sedation, but what is the preferred? The first part was, what is the preferred process in handling toxic amphibians, which surprises me. This was upvoted by other people as well. I guess other people were dealing with this issue. What would you say to that?
So the big thing is once again wearing those gloves, right? So that's going to protect you as the handler from any of the noxious substances that are going to come off that, and it's really easy to wash your gloves off afterwards when it comes to handling those toxic amphibians. Particularly with some of the species that have large parotid type glands as well. You just want to make sure that you're not squeezing those. Some people will actually, probably not necessary, but some people will wear goggles as well when they're hitting those, if they have to be up and close to those parotid glands as well. And then her second question there.
I'm going to skip to the third one.
Okay,
what
perfect.
Body language to look for with a stressed amphibian?
Yeah, so the big thing with stressed amphibians is they're going to be looking for routes of escape. So they're going to be very secretive. They're going to try to hide. Big thing is their pupils will become very wide and very dilated, and that's a very stressed amphibian as well. And will have an elevated Gular rate as well with those amphibians. As they start to try to pump their lungs up for that stress escape response. So those are the big things, is to try to look for that. They're trying to escape actively. They've got really eyes wide open, very dilated pupils, and trying to escape.
And Janet, I'm skipping the middle part, but if Dr. Whiteside didn't really address an answer to that, you feel, then just let us know through the chat box and maybe we can come back to that. Shannon asked about using the Doppler probe from outside the plastic container. And actually you can see that Allison actually replied about using a plastic bag. So thank you so much, Allison, for replying to Shannon. But I think that she was asking about specifically the grocery containers that you mentioned. Does that work for
it
the
does
Doppler
actually
probe?
yeah
Okay.
So that picture in the presentation of that leopard frog, it's just underneath the container there. We put a drop of gel there, and it'll actually because it's in a water-based thing, that water acts as a great sound medium as well, so it'll pick it up quite nicely.
Thank you. I had every intention of leaving Kaylin's question towards the end, since it's not actually sedation, but it was also upvoted, so other people were very interested. She asked, does using an insulin syringe or needle rupture the red blood cells? And
it doesn't. No, actually, I've never had that happen. Big thing is it's a slow draw anyways, because too much pressure will actually collapse the vein, and so it's a slower draw. And so sometimes what you'll need to do, particularly if you think it's going to be a challenging one, is I pre-heparinize my syringe as well, to make sure I can just do a nice slow draw that doesn't clot.
Thank you. Allison and Hannah had a question or comment about the gular flutter versus coelomic movement. There's some controversy over whether the gular movement actually is true respiration, if it's more behavioral. How helpful is it for monitoring? I don't know if I should read the whole thing, but that's the gist.
Yeah, so it's a bit of a challenging one, because sometimes you actually won't pick up a lot of the body movements when it comes to respirations, because a lot of the body movement actually is the active expiration as opposed to inspiration. Because, as I say, you're actually not having an aspiration type of respiration with amphibians like you would in a reptile species or that. So that's, in a reptile, absolutely, for sure. In general, most of what we tend to monitor is that gular movement. It tends to be the most consistent in terms of monitoring rate. The big thing, though, is that gular movement can, as you saw with that horned frog in the presentation, when they're a little bit stressed, it actually is increasing as well. But once they actually start to calm down, it's kind of a great way to actually look at that, because that's the most effective way that they actually are pulling in small amounts of air to be able to inflate their lungs.
Thank you. Majid asked about a specific combination listed there: 2.5% dextrose, 0.45% saline. He wanted to know what your opinion was in using that in axolotl.
Oh, I mean, the big thing is that is probably actually going to be hypertonic compared to the osmolality of the axolotl using that dextrose. So you may not get as good hydration with that, but you definitely, in terms of energy, you'll get transfer of glucose across the skin. Good for that. Yeah.
We have another question about fluid therapy. There are some textbooks that say don't use fluids with potassium in them, and he wondered what you thought about that, especially in critically ill amphibians.
Yeah, that's an interesting one. Some people have talked about that just because, what the effect that it might have on the heart. But the amphibian heart doesn't have a Purkinje system either, compared to, like an avian heart or mammalian heart. And I've never had an issue using, as I say, plasmolite or normosol, and even in any critically ill amphibian. So.
Thank you. And Rita wanted to know, well, she asked about how you like to aerate the water. You mentioned a stone, or actually the anesthetic machine, but she also asked, what is the maximum time for anesthesia if aeration is not possible? If you had any suggestions or thoughts about that.
Yeah, I guess it depends on what you have available. So certainly with the aeration of the water, quite often I'll just use a fish pump. It works quite well. If people don't have a fish pump, I say they can connect it directly to their oxygen line with tubing as well. And so, yeah, so I'd say usually, I think the big thing with, if you don't aerate the water, is that that MS-222 in particular can really lower the oxygen saturation for those amphibians. And so if you have that animal out and you have the ability to at least have flow by oxygen over top of their skin, that's what I would recommend, even for shorter procedures if you can.
Thank you. Gael asked about topical administration, direct topical administration. Is there a certain location or skin area that you would recommend that's more efficient at absorption?
So for topical, no. I mean, most of the time we tend to put it over the back because that's where it's the easiest to do. You know, because most of the time the amphibian is going to be sitting in a normal position as we're applying that. So a lot of people kind of put it over the kind of the mid coelomic range, or sometimes over the dorsal pelvis. Those tend to be the places where I tend to put most of the topical anesthesia when I do that. And then what I've actually done in some cases, if I want to have a little bit of prolongation, and I'm working on the top part of an animal, is that I put a little saturated gauze just underneath the chin area and have little frogs kind of sit with it in between their hands as well, and with that kind of gel that you can produce, and that will extend your anesthesia for you as well.
Thank you. I'm actually scrolling down a little bit to Kim's question about MS-222. It's upvoted a bit, and she asked, how do we safely dispose of immersion anesthetic agents?
Yeah, so what we do is, once again, it depends on the laws around your cities or your states or provinces, things like that. So for us, we actually send ours to biomedical waste, and so we actually will put it into a container afterwards, and then send that container once it's filled to biomedical waste for incineration.
Thank you. Laura asked, when you're soaking a gauze with halogenated anesthetic like isoflurane, do you use a certain amount, or is just enough to soak the gauze adequate?
Yeah, so for the open drop method, I just use enough to soak the gauze adequately. So usually ends up being about 1 to 2 mLs, and then as I say, I like that little container, so I just put it inside that little container when I do my topicals like that, or my aeration like that. So yeah.
Thank you. Joelle asked, can you expand on oxygen flow rates? That's the question. So I don't know if there's anything more you wanted to add about what you said about that.
Yeah, so when I'm having that flow by oxygen, as I tend to use very, very low flow by oxygen rates. So usually, for a small amphibian, you may only be using like 100 mils, basically the smallest dilation that we can have with our Bain circuit. So usually for us, it's about 100 mLs per minute flowing over top.
Thank you. Anastasia asked, are you concerned about staff safety, or when you're using liquid sevoflurane or isoflurane? You mentioned it in passing, but she just said, since I imagine that quite some fumes escape the bottle easily when you open it to get a drop for the amphibian patient.
Yeah, I mean, it's always something that you want to be aware of. So you want to make sure you're using it in well ventilated areas. But as I say, you want to try to be as efficient as possible when you're doing that as well. Yeah.
Thank you. Jumping back to monitoring, Steve asked, I didn't hear a heart rate range as you did with respiratory rate. Did you have any?
Yeah, so once again, it's very species dependent, and that's why
Right.
it's a really good idea to get your kind of your baseline before you do anesthesia. I find that most of the amphibians I tended to look at tend to be anywhere from 40 to 70 beats per minute, I would say, is where most of them tend to sit. For leopard frogs, for example, it's kind of in the 50 to 60 range. For some of our smaller species, it might be a little bit higher in kind of that 60 to 70 range. And then when they're under anesthesia, it's not uncommon to actually have them down in the 40 to 50 range quite often. But as I say, bigger thing for me is to look at what is my baseline, and then once again, if I get below that, more than a 20% drop in anesthesia, I know that patient is too deep. If we're at 30%, I'm making sure that I take action on that.
Thank you. Jason had an interesting question. What would you recommend in a home euthanasia setting? Alfaxalone plus an alpha 2? Question mark.
Oh, in a home euthanasia setting, I mean, I probably wouldn't recommend a home euthanasia setting, but I tend for euthanasias, it's certainly metatomy and alfaxalone is not sufficient enough on its own for euthanasia, and so you're going to want to use something on top of that, whether that is, injection of intracellular pentobarbital, for example, and then pithing.
Okay. Yeah, I don't know the situation, but I know there's some mobile veterinarians, and maybe that would be the situation.
Oh, okay. Yeah. Yeah, so yes, I mean, for me, obviously euthanasia wasn't the topic for this talk, but for me, I tend to use MS-222 or high doses of dex and alfaxolone to cause really, really heavy sedation or anesthesia, and then pith them. Yep.
And I will just add too that you mentioned euthanasia in your other webinar that you generously did on
Yep.
emergency. So Jason, you may want to check that out. There's more information there. Lindsay asks, how do you keep the airway moist when using inhalants?
So big thing with airway being moist is you just keep the frog moist itself. You'll actually keep them. You keep the body will take care of itself in terms of that. So I actually don't end up doing anything to the airway itself. Basically I will just make sure that the amphibian stays moist during the entire procedure, because it'll absorb as much fluid as it needs to keep that respiratory system from drying out.
Thank you. Michelle and Shirley had some questions about dexmedetomidine. I thought you mentioned the atipamezole dose. She wrote, what dexmedetomidine to atipamezole ratio do you use?
Yeah, so it's like a 10-to-1 dose, but some people will use 50 milligrams per kilogram as well. But yeah, I usually go with a 10 times my dose that I've used.
Thank you.
On a milligram basis.
Sorry, were you going to say something else?
Just on a milligram basis, yeah. So if I use like 1 milligram, then I would use 10 milligrams of atipamezole to reverse it.
Right. Shirley asked, was the dexmedetomidine alfaxolone protocol for IM use?
Yes.
Okay. Thank you. Okay, I'm just going to double check real quick, scan the list for upvoting. Sharon, I believe he just answered your question. If he didn't, let us know. Christy asked, if the environmental temperature is below the preferred optimal temperature zone in the post-anesthesia period, what is the best way to warm the patient?
So I guess it depends on what you have available in your clinic, but quite often what you can do is use something like if you have a hot dog warmer, you just put some towels on top of that, and then you can actually then put your container on top of that, and then just use, like, once again, a temperature gun to make sure that you're within that preferred optimal temperature zone. So quite often that's what we can use, is to kind of even just warm them up a little bit into their higher end of their preferred optimal temperature zone, is just by putting some towels on top of your hot dog warmer.
Thank you. Jennifer asked about desflurane for anesthesia. Do you have any experience with that?
I do not know.
Okay, thank you. I haven't had a chance to read this yet, so this may not go well, but what is your emergency response protocol if an amphibian is not recovering well, or it seems like it is not getting lighter with reversals or freshwater solution washes?
Yeah, so I guess it depends on what I've used for that amphibian. Definitely one of the big things is you're going to have to offer support. So making sure it's well hydrated, make sure it's within the preferred temperature zone. It's been rinsed off really well. One of the things that I've often wondered about, particularly with MS-222, is whether you could use something like intralipid to try to enhance recovery. It's something that one of the anesthesiologists that I work with, him and I have had those conversations about whether intralipid would be something that would help enhance MS-222 anesthetic recovery. Certainly with any of the injectable combinations, if I have a reversal available for those, I'm going to want to make sure that I'm using those reversals as well. But that being said, sometimes amphibians can take a long time to recover. I've had, sometimes amphibians where everything goes well, they're induced well, they seem to be under a stable plane of anesthesia with MS-222 afterwards, and then they take several hours to recover when they should be recovered within an hour. So sometimes it's just patience and once again, just providing good oxygen support, and say flow by oxygen can do that for you, and keeping them moist during that recovery period, and then doing those periodic heart rates to see what's going on there, and watching for the coelomic and gular breathing to return.
Thank you. Just briefly, I saw that Jason added a comment. He said that he was more inquiring about pre-euthanasia sedation, which I think you addressed a bit, but just wanted you to be aware that was part of his question. Although we do have, some people who are mobile and some people are rehabilitators, so they still were curious.
So any of those things, like alfaxolone, dexmedetomidine alfaxolone will give you really good pre-sedation or pre-euthanasia sedation. Yeah. Mauricio
had a question about what you can do topical anesthesia if it's not, if you need to try to reverse or not reverse it. Okay, he wrote, is there any reversal agent for topical anesthesia toxicity? And Kaylin wrote, my guess would be to flush the area clean with dechlorinated water to dilute anything still on the skin. That sounds reasonable. Is there anything else that you can recommend to try for this patient when you're
Yeah,
having?
so once again, like, if it's something like a, benzocaine or MS-222 that you've used, for example, yeah, making sure that that amphibian is well rinsed off, get them up into the higher end of their preferred optimal temperature zone to increase their metabolism and oxygen demands, because that way they'll hopefully start to breathe better soon, because it's decreasing oxygen and not increasing carbon dioxide, which is a driver for amphibians to breathe as well. So that'll help by increasing their temperature into the higher end of their preferred optimal temperature zone. And then, as I say, Dopram, I haven't had much success in amphibians using Dopram. I know that there have been some clinicians that recommended that 5 milligram per kilogram dose, but I'd say in my hands, I've never really appreciated a difference when I've tried it. But certainly something that might help, won't hurt.
Thank you. Caitlin asked, with regards to using clove oil, I have only ever heard of it being used for euthanasia. Also, I have heard it basically just suffocates the creatures. How true is this? I know you said you don't recommend it, that there's other better choices, but.
Yeah, so it does seem to produce anesthesia or sedation, I would say, and the way that that's doing that is basically by numbing the animal. That's why it's not providing good analgesia associated with it. So it's kind of the similar principles as it is in fish. It kind of basically kind of makes them numb and sedate, but doesn't really provide much in terms of pain relief for them.
So did I misspeak? Would you say you do recommend it?
I don't recommend clove oil. No, I don't recommend it. No, you're correct.
Okay.
And I'd say because of the fact that it doesn't provide good analgesia, it tends to be all over the map in terms of the quality of induction, as well as the potential for prolapse of their stomachs, gastric prolapses.
Thank you. Marcel has a question about fluid therapy, and I don't know that I completely understand. Well, I'll just read it. If using plasma light 50-50 with dechlorinated water, should tap water or I think that's distilled water be used?
Yeah, so I've just used tap water. That's the nice thing about our tap water. I mean, it depends on where your tap water is coming from. In our case, it's city water, so we know that it's sterile, and it's got an appropriate concentration of different salts and stuff within it. And so yeah, I'll just use dechlorinated tap water with the plasma light. Other people will use sterile water. You can use bottled water as well as some people will just keep bottled water in their clinic for that reason as well.
Thank you. The next two questions that were upvoted are by Erica and Alessandra. Before I read them or mention them, I'm just going to tell these guys, if they're still here, that you did your emergency webinar recording talks about analgesia, so they may want to check that out. But they did ask what you would recommend for analgesics in amphibians. I don't know if you have a short answer you'd want to
Yeah,
share.
so the three things I would recommend. One is you can use local anesthetics to infiltrate, depending if you're doing like a minor skin wound or something like that, or toe clip or things like that. Local anesthetics are great for that, and I tend to use kind of that 5 milligram per kilogram for lidocaine or for bupivacaine. Bupivacaine gives you about 3 to 4 hours of analgesia associated with that. And then in terms of injectables, the two most effective in amphibians are opioids, but the opioids you have to use really high doses, and once again, it's very species dependent, but sometimes up to for example, with buprenorphine, up to 50 milligrams per kilogram. And then with the other one is the alpha-2 agonist. So dexmedetomidine has been shown to be as effective, almost as effective as opioids in amphibians. So I tend to use a lot of dexmedetomidine as well for analgesia.
Thank you. Eric asked, for benzocaine, what products do you recommend for creating a stock solution? And do you worry about any of the additives in these affecting amphibians?
So just basically the straight oral gel with no other ingredient into it. So just basically the oral gel with the benzocaine is usually about 10%, and then you have to dilute it with ethanol first of all to kind of help get that benzocaine into a water soluble solution, and then add your water afterwards to make up the solution.
Thank you. Nicola asked, I'll just read what she asked. When an amphibian heart rate drops under 20% compared to baseline, do you always reverse the anesthesia, or could you use other drugs? And I wasn't sure if I should read this because I'm not sure if she's asking what she's asking. And in case, what would the dosage be for these other drugs, I guess is what she's saying.
Yeah, so as much as possible, I always try to get the animal back to their normal physiological state on their own. So if I'm at a point where I can actually lighten the anesthesia, or by either, for example, say I was prolonging anesthesia by dripping, my stock solution of MS-222 at 25% of the induction concentration, I'll stop that, rinse off the animal, for example, or even sometimes just changing out the water to because if there's any kind of metabolites that are within the water that are causing still some deepening sedation, gets rid of that in the amphibian as well. If it's a situation where I've used, for example, dexmedetomidine and alfaxalone, I can do a partial reversal, so about 25% reversal with my dexmedetomidine to see whether that helps, and that might help. In terms of what other drugs you could use, some people will use atropine. And I have certainly used atropine in the past when I've had heart rates that go really, really low, and I tend to use it at around 0.05 mg per kg in amphibians. And you can either go down the endotracheal tube, or you can certainly just give it intramuscular if you can't get IV access. And I find the intramuscular works fine for atropine.
Thank you. So we just are going to do just a few more questions if you're doing okay, and then we will be done, I promise. Is that?
Yeah, no worries.
Okay. Okay. All right. Ashley asked, does MS-222 cause a drop of oxygen due to the medication itself, or are there other factors?
Well, I mean, basically MS-222 is kind of like a local anesthetic in terms of the way that it works, even though it does provide some dose-dependent sedation and analgesia. So it's probably crossing into the blood-brain barrier and inducing our anesthesia, through that effect. So yeah, I mean, I don't know other than that what to say.
Nope, that's great. Thank
yeah.
you. Catherine asked, which plasma light do you use? Plasma light 148?
Yes, yeah, I use P148, so it's got a pH of 7.4.
Okay, and she did have a second part about flumazenil. I believe that flumazenil, you mentioned the dose, and it's probably in the table, but she wanted to know what the dose was for midazolam reversal.
Yeah, so yeah, usually it's a 1-to-1 with your dose of midazolam, but I think it's up at 0.15 mg per kg, I think is the dose that most people are using. But yeah, I'd have to go back and look at my table.
Okay. Let's see. Everything else. Craig asked, what are some types of, well, I wouldn't go to read this. What are some types of water-soluble gels? I'm not really sure what that means. I guess he's asking if there's a brand that you like, or if you're making sure you use sterile. I don't know what he's asking, honestly.
Yeah, if it's for the benzocaine, I use the Oragel. I mean, it's something that's is readily available here, but I think it just depends on what country you're in and what the brand names for your benzocaine are in terms of what you can use.
Now, but for some of the halogenated anesthetics, was that one of the recipes where you could mix it with? Am I making that up?
Oh no, sorry, yes, yeah. So that's just a sterile KY lube or KY jelly.
Okay.
So any of those sterile lubes are fine for that. Some people will just use the ophthalmic, sterile ophthalmic lube as well, and that works well too.
Okay, thank you. I think that might have been what he was asking.
Oh, okay.
I'm not
okay,
positive.
Yeah.
Ashley asked, do you have a preferred temperature gun?
Nope. Just whatever's available. So.
And the last question, I probably shouldn't even, well, it's Primrose asked, what instruments or diagnostic techniques do you like to use for blood work, especially with how small our patients are? There are limited analyzers that can read our small volumes.
Yeah, so for most of our blood work, I actually will send it out to either IDEX or Antec. I find they can do amazing things with small volumes, and I prioritize in terms of what I'm looking for. So if I think, for example, I'm dealing with a renal case, I'm going to prioritize urea, in that animal over some of the liver enzymes, for example. The other big thing is if you get a lot of lymph, don't throw it out. Some people I know, will take it and then they squirt it out the syringe. You're like, no, because the lymph you can actually run your chemistries on as well too. You just obviously can't run your CBC, but you can run your chemistries on. And the other thing you can do is if you can make even a small slide from what's left within your needle, you can do a estimated white cell count off that, and then that way you can utilize the rest of your heparinized solution or heparinized blood for your chemistries.
Thank you. I said that was the last question, so I'm going to make that the last question. Plus, it's 4:30. Thank you so much.
You're welcome.
Thank you so much for your time. There's just a couple which I will email you. One isn't actually anything to do with anesthesia, sedation, or even analgesia, but I will email it to you anyway, if that's okay.
Yeah, and certainly I talked about feeding anorexic frogs in my last presentation too.
That's true. Thank you for mentioning that. So Jade, if you're still here, check that out. Before I close, do you have anything to add, Doug?
No, just thanks very much for the invitation to speak and for everyone who joined.
No, thank you. Thank you so much. And thank you all for attending this Lefebvre Vet webinar, Amphibian Sedation and Anesthesia by Dr. Douglas Whiteside. This is Crystal Pollack of Lefebvre Vet. I'm signing off and wishing you all a great day, night, morning, and everything in between. Thank you so much.